covering your
RT week, everyone. My name is Brian Gaden. I'm a respiratory therapist and sleep tech. I'll just say more than 20 years and leave it at that. My current position, I'm the respiratory and ventilation specialist for Philips Respironics, typically doing training and support of the Trilogy and Coughassist. Coughassist is what we're going to show you today. So one of the things I mentioned last time I was here, Adam and I sat and talked about the new way to titrate the Coughassist to get better results. So there's really two things that we can accomplish therapeutically with the Coughassist. One, obviously, is assisting a patient to clear secretions, and two is to use it as a lung volume recruitment tool. And I think it's fairly well been underappreciated as a lung volume recruitment tool. Many of the patients that you're going to use this on are diaphragmatic dysfunction type patients, so neuromuscular disease, spinal cord injury, that sort of thing. And what we're trying to do with them is we're battling atelectasis, particularly in the bases. And so having this as a tool can really help. A couple of numbers that I want you to be familiar with. One is the 2 peak cough flow numbers. We know that if you have a peak cough flow of less than 150, you're not able to move secretions. And the only way really to get those secretions out is with an artificial airway and suction. The other number is 270. If you have a peak cough flow above 270, you're effectively moving secretions. A bigger, higher flow number, you're going to get better results, obviously, so the more is better. If you're between 150 and 270, obviously you want to use a device like this to help get you as close as we can get. So if you're at maybe a 200, you could use the Coughassist to get them over 270. You get those secretions cleared out, you could probably avoid a lot of section. There are a lot of patients that fit that category. Okay? So what I want to do now is I'm just going to show you a couple of things, and I'm going to mention towards the end a couple of things that are new on the Coughassist. When we talk about settings, let me make a couple of quick adjustments on this. And I know it's really hard to see, so if you want to come up closer, don't be shy. I haven't bitten anybody in at least 3 days. 2 days.
I'm going to stop for just a second, Brian, because these guys have to get down to report.
Okay.
So if you guys want to go to report, I'm going to have BJ and Chris kind of stay, and then they can kind of help give you that information afterwards. If you feel strongly that you want to see it, you can just let us know, and we can let them say.
And if you would like to set up a larger session where we could do a full hour on it, we could probably do that, and I could probably do a CEU for it too.
Yeah.
So it might be something you want to look at in the future.
Yeah, I think, Adam, if you want to.
Is that yours or mine?
This one's mine, this one's yours. Things that'll set it up for the next one, because there really isn't a way in 10 or 15 minutes to show you all the things that would really be helpful. But I want this to bring to your attention so that you're aware of what it can do, right? So if we look at these settings here, what I'm going to give you now this is your goal. This is what you're working towards. It's going to be pretty rare that on your first try with a patient you're going to get to these goal settings, because they have to learn how to do it. It takes a little acclimation time to get that. But in all cases, we want these to be your goal. So let's talk about the inspiratory side of it. We want the inspiratory portion, our goal, to be 40 centimeters of water pressure. That's because we know that if you apply 40 centimeters of water pressure to an airway and hold it for 5 seconds, you will recruit in excess of 90% of the lung volume. That's a big improvement for some patients. On the inspiratory time piece, we want to make sure we titrate that individually for a patient. Here's why I say that's important. It's actually very important. The biggest factor that we can do to improve peak cough flow in a patient using this device is to have the device and the patient well synchronized and well coordinated. Okay? That is far and away the biggest factor. Where we get off base typically, and where it becomes dysynchronous, is when our inspiratory time is set incorrectly. Here's what I mean by that. If you were to you've probably told somebody at one point in time to take a deep breath and cough, right? So let's cover our mouths and let's do a deep breath and cough real quick. Okay? Let's break that down into its components. First thing is a quick inhalation all the way to TLC. Once you're at TLC, you don't stop or wait. Immediately you close your glottis, you compress your abdomen, and you burst out that air, right? That first burst is usually your highest peak cough flow. The second burst is still pretty good, but it decreases. And so after you get basically to your third and beyond, your peak cough flow is diminished, where it's really not effective, and now we're approaching residual volume, right? So keep that in mind when we talk about the expiratory side. When I say the inspiratory time is important, is we want to set that inspiratory time so as soon as the patient is full, as soon as they've reached TLC, There's no wait, there's no lag. Immediately it triggers into the negative portion of the cough portion. I'm going to show you here what a good cough, because this is set, I've done this enough times, I know what my settings are. I'm going to show you what a good cough looks like and sounds like when it's well coordinated. And then I'm going to change it where it's not well coordinated, and I want you to see and hear what that looks like. Because when it's not well coordinated, your peak cough flow diminishes greatly. It's really uncomfortable for the patient, and they start to think it doesn't work and they can't do it. And if they believe that, they're right. So, right, first things first, I'm going to ramp it up, and I'm going to do a good cough for you. So, cards if anybody wants one.
Before you go.
Yeah, before I toss them in the air. Everybody knows CPR, right? In case I fall out. No? That's not a lot of confidence inspiring. All right, so here's a good cough. You notice there my peak cough flow is what? 485. That looked and sounded pretty easy, right? Now I'm going to set this, and I'm going to set my inspiratory time too long, just so you can see what that looks like. Now you'll see my inspiratory time's a lot longer, and you'll see what a poorly coordinated cough looks and sounds like. You won't get to know what it feels like until I come back and make you do it. But it's not a lot of fun. So what happened there is, because the inspiratory time was too long, as I'm trying to cough out, the machine is still pushing in. You heard that squeak. And as soon as that happened, that pressurized all of my ear canals and everything else. It's very uncomfortable. Look what happened to my peak cough flow. Went from 485 to 203, right? So peak cough flow is improved by getting it well coordinated. Comfort and ability for the patient to do it is improved. So when I say these are our goals to set these, we want to get the inspiratory time right. But our first thing is to give the patient, on their first series of coughs, a low pressure, whatever we've got to do, so they learn how to do the dance step. Once they've learned how to coordinate it, moving the pressures up is easy. If you start with too high a pressure and you get out of coordination, all bets are off. They're going to look at you like you got four eyes, and there's no way they're going to do that, right? So here's how I do this. For a pediatric patient, I would probably start off with an eye time of 0.5 seconds. Oops, sorry, over here. And what I want to show you is, I'm going to do it for an adult, which I start with 1.5 seconds for an adult. But if you come up here close and look, you'll see when I start to breathe in, there's a little blue dial here. And that blue dial, when it reaches 0, that means the end of that inspiratory time is up, right? And that's when it's going to transition. So when I tell the patient first, I want them to do a couple of quick coughs. Just tell them we're testing it, right? It's not going to feel just right yet. But when I start to cough, you want to look and see, is the time expired yet or not? So that'll tell you whether your inspiratory time is too long or too short. So look right here. It's kind of hard to see. And you'll see that little dial. You see it right there? So you could tell that one was a little bit too long. You heard the squeak, right? So first thing we want to get, try to work up to 40 centimeters. We're going to, if this 1.5 seconds is too long, I just go ahead and shorten it. And then we're going to use that dial to know when to cough. Okay? Does that make sense so far? If it's well coordinated, it works great. If the patient likes it, you get good peak cough flow. If it isn't, that's the number one takeaway point. You're basically almost wasting your time. Okay? Expiratory time and expiratory pressure. Because most of the patients that we do this on are going to be susceptible to de-recruitment or alveolar collapse, what I want to make sure is that the net effective pressure in this device is positive. So my inspiratory value of 40 and my expiratory value of negative 35, that's a net pressure of positive, and I always want to try and keep that if I can. Okay? I don't want negative 45 and 40 because that's a net negative pressure in the lungs. I don't think that's a very good idea. We could de-recruit. The other thing is this expiratory time. Remember, we want about 2 bursts. After that second burst, your peak cough flow is diminished anyway. You're not really moving secretions. And I don't want to apply negative pressure to a lung at residual volume and de-recruit them again, right? Because now we're doing the opposite of what we're trying to do with these patients. So I look at this, and when I see 2 bursts go out, that's what my expiratory time is. I would rather be a little too short on my expiratory time than a little too long, right? That makes pretty good sense so far? So that's how we're going to set it up in terms of titrating it for a patient. The second function of this that you can do is called lung volume recruitment. Remember we said 40 centimeters of water pressure for 5 seconds recruits 90% or more of the lung volume. So because we have 3 presets on this, I usually will set my number 3 preset. You'll see it here. And what I've got here, I'm going to show you, is look at my inspiratory time and pressure. What does it say?
45.
Right? So this is a lung volume recruitment. What is my expiratory time and pressure? Nothing. It's just an inspiratory maneuver designed to open up the airway. The other thing that I've got turned on here that you'll see, and I put it on this breath because I can accentuate it so it becomes really obvious, is the oscillation feature, which is a new component of the Coughassist. The idea is that if we oscillate the pressure up and down, we vibrate the chest similar to CPT or a vest, and that helps shake those secretions from the bronchial tree and helps you to move them out, right? So I'm going to do one right here. This lung volume recruitment is a passive maneuver, so all I want to do is the patient triggers it and just relaxes and lets the pressure fill the lungs and hold it. You'll also see when I do this, it's going to go and you'll see a little bit of the vibration. All right, you ready? So that oscillation feature is shaking the chest. How do we know how to set the oscillations? I've done some bench testing, and I found that, there are 2 settings that you can do. So you can put oscillations on the inspiratory side, on the expiratory side, neither or both, right? I'm going to recommend to you to use it on the inspiratory side only, because the way that the oscillations work is you'll set a pressure. So the best one is the highest, 10 centimeters of water pressure, which means for this, it's going to be 10 above and 10 below what this setting is. If I had an expiratory pressure, it would be 10 above and 10 below that on the expiratory side, okay? What I don't want to do is as the patient's coughing out, having those big fluctuations in negative pressures probably closing airways distally, and you're trapping secretions by there, and we don't want to do it. The way I look at it is if you can't adequately shake it during the inspiratory side, you're probably not going to help on the expiratory side anyway, and I don't want to take the chance of trapping secretions, right? Does that make pretty good sense? The other thing that you set here is a frequency of the oscillations, and I found that between 7 and 10 hertz, 7 and 10 cycles per second is best. When I tested it at higher frequencies, it just got attenuated in the tubing and we lost a lot of it. If you compare this to IPV, everybody's used IPV before, there are going to be, if you took 100% of the patients that need IPV, some percentage of those are also going to benefit or pretty well from the Coughassist, but there's some IPV patients that the Coughassist just isn't going to be able to do as well with. The reason for that is with the IPV, the phasotron is proximal to the patient, and so that pressure generation pulse is really well transmitted. In the Coughassist, it's behind all of this tubing, and so you just can't always shake the lungs as well as you can with that IPV. Just keep that in mind. How can you tell? You can auscultate the chest. You can watch for chest wiggle. Those things are good indicators as to whether, how much good you're doing or how much therapeutic benefit you're getting from it. Right? Made pretty good sense so far? Right? Anything that I've said that doesn't ring true or doesn't make sense with what you know about pulmonary physiology? Nope. Okay. So there's one other feature on this, and it's the newest one that we just updated today. Is actually brand new, so even if you'd updated it before, it wouldn't have been on here yet, so we'd have to update it anyway. It's called Advanced Auto Mode. If I go into the settings, you'll notice that there's the presets. There's going to be a mode. You'll have 3 choices. Manual, it's like the old Coughassist. Auto, which is the machine's going to cycle on its own, right? And then Advanced Auto. Advanced Auto allows you to set pre and post lung volume recruitment breaths. So if I put it in Advanced Auto mode, I'll say how many breaths do I want? Say 5. At what pressure and what time? Pressure and inspiratory time, and it'll do those 5 breaths. Then when you're done, then it'll go into the Coughassist mode that you've got set, and then I can also do post breaths if I want to do it. The idea behind that is that, remember, these patients were fighting atelectasis. That's our enemy in these patients. We have to be vigilant about keeping the lungs open for them. And so what we want to do is recruit good lung volume. That gives us a better and more effective cough. It's going to improve our peak cough flow if we have a higher lung volume. we're going to do the coughs, get the secretions out, and then we're going to leave them with that lung volume recruitment to make sure the lungs are good and open at the end of the treatment, right? Because when we get rid of the atelectasis, we improve lung compliance, we decrease work of breathing, and people with diaphragmatic dysfunction, it's that work of breathing that's getting them because they just don't have the strength to do it, right? Does that all make pretty good sense to you? So that's all I will release you for now. What I suggest doing is that I can come back at another time and we'll do the full piece, and you'll get some hands-on experience with it because there's nothing